Hi everyone, welcome to your final week. This is lecture 5A. The topics for this session are going to be healthcare funding and health-related insurances and strengths and weaknesses of the Australian healthcare system. We're just going to quickly go through the historical development of the healthcare system. So in the early to mid 20th century, the Commonwealth Department of Health was established. This was a result of the Spanish influenza epidemic, which happened in 1921. So the key focuses during this time were quarantine, disease prevention, and public health education. We still do all of those things. The public hospital, was ill-equipped and unable to meet the demands or raise revenue to cover the costs. So they had all these people unwell, but they didn't have the equipment to treat them. There wasn't enough funds to actually pay for any of that equipment either. So mostly private hospitals were used, but they were really expensive, so not everybody had access to healthcare. The National Health Insurance Scheme was proposed, but it was twice rejected in 1928 and 1938. The Pharmaceutical Benefits Scheme was introduced in 1944, and this still stands now. In the mid-1940s, the Hospital Benefits Act was established, and that meant free treatment in the public hospitals. Hospital Benefits Act ceased in 1949, so it only lasted a few years. Only Queensland maintained free treatment. Okay, so in 1950, the first national health scheme introduced by Menzies government, so individuals could choose whether they were covered by insurance or not. And individuals were free to choose whether they wanted the insurance. The Commonwealth funded organisations to provide elderly accommodation in the early 1950s. The cost for the Pharmaceutical Benefits Scheme and National Health Scheme increased, and the first Aboriginal Medicine Service was established in Sydney in 1971, and Medibank was established in 1975, and this was the first universal healthcare insurance. Okay, in 1975, 50% of the operating costs in the public hospitals were paid by the Commonwealth to the states and territories in return for free health services for all Australians. In 1978, so 3 years later, the medical rebate was 75% of the scheduled fee. Bulk billing was only available to pensioners or healthcare card holders. Some of these things might not make sense to you yet, but we're going to explain what bulk billing means and rebates, etc. 1980, the deinstitutionalisation of mental health facilities was introduced. 1981, free hospital service was restricted to pensioner health card holders and a few other eligible individuals. So those without insurance had to cover their own medical costs. So as you can see, Australian healthcare was not really easily accessed, and there were lots and lots of changes throughout this time. In 1984, Medibank was renamed to Medicare, and that's what we call it today. So this saw the re-establishment of bulk billing. Rebates were increased to 85%. There was free public hospital services to all Australians, and the Medicare levy was set to 1% of the taxable income. 1991, introduce of the safety net. So we're going to discuss that as well. 1995, Medicare levy was increased to 1.5% of the taxable income. 1997, there was the Medicare levy surcharge introduced. All of these things are still around today. 2004, so Medicare made some changes to the safety net that was introduced in 1991. So now 80% of all hospital Medicare expenses were to be covered by Medicare for concession card holders or individuals under the family tax benefit once their out-of-pocket expenses reached a particular threshold in one calendar year. So some of the achievements in the 20th century in relation to public health and promotion included improved sanitation, clean water supplies, control of infectious diseases, control of non-communicable diseases, reduction of the infant mortality rates, reduced dental damage, and campaigns to reduce tobacco intake, cardiovascular disease, etc. So they did do some fantastic things. Okay, so Medicare. What is Medicare? You've probably heard this thrown around. You probably have that little green card in your wallet, but don't really know what it does. So that was introduced in 1984. So similar model created in 1974, which was called Medibank. So basically, Medicare provides free or subsidised treatments by healthcare professionals such as doctors, specialists and optometrists. So the aim is to give Australians access to adequate, affordable healthcare irrespective of their personal circumstance. So everybody within Australia that is either a permanent resident, or was born here basically has access to Medicare. So your major elements here: free treatment for public patients in public hospitals, so includes inpatient medications, diagnostic testing, allied health, etc. Benefits or rebates for professional health services within the Medicare benefits schedule, and we're going to discuss that. Subsidized costs of medications in the pharmaceutical benefits scheme, and we'll discuss that one as well. Okay, things that Medicare does not cover. It doesn't cover most dental examinations and treatment, a lot of physiotherapy, occupational therapy, speech therapy, eye therapy, chiropractic services, podiatry and psychology services, acupuncture unless it's a part of a doctor's consultation, glasses and contact lenses, hearing aids and other appliances, home nursing, unnecessary clinical, medical and hospital services, so including cosmetic surgery, ambulance services, so free for concession card holders and pensioners for necessary ambulance transfers. Okay, so eligibility for Medicare, so who can actually access it? So Australian or New Zealand citizens, permanent residents, applied for permanent residency and meets a particular set of criteria, or covered by a reciprocal healthcare agreement with another country. So just to expand on this last point, so the RHCA, so this agreement basically says that Australian residents receive help to cover the cost of essential medical treatment when they visit other countries that are covered by this agreement, and residents from those countries can also receive help to cover costs of essential medical treatment when they're in Australia. So basically there's an agreement between the two countries that says if any Australians visit this country, we'll give them some access to our healthcare at a free cost or subsidized cost, and vice versa when they visit Australia. So some of those countries are listed here. Now they all cover different things, and if you look them up, it tells you what is covered and what's not covered. Okay, the Medicare benefits schedule. So basically this allows for reimbursement for health services for those that are eligible for Medicare. So an MBS or schedule fee is set by the government based on what they deem appropriate for a particular healthcare service. So that could be, we believe you should be paying this much for a GP service, you should be paying this much to see a cardiologist, etc. So services covered by the MBS are listed in the schedule. So if you looked up the schedule, it would tell you what was covered, and it would also tell you what percentage of that service fee you should be reimbursed. So if you have a Medicare card and you visit a GP, you should get back 100% of the schedule fee to see the GP. If you are a private patient in a public hospital or in a private hospital, you should get 75% of the schedule fee for treatment within that facility. Doesn't include your theatre fees, medications or accommodation though. And if you visit a specialist, you should get 85% off the schedule fee. So it's all about rebates. I'm sure you've heard Medicare rebate. That's what this means. So there are limitations to it though. So just because the MBS says that a GP should charge, for example, $100 for a visit, that doesn't mean that they'll charge you $100. They can charge you whatever they want. They want to charge you $500 to see them, they can. So what the healthcare system has is a gap fee or payment. So if your GP does happen to charge that $500, for example, when the MBS says they should only be charging $100, then the gap between that $100 and the $500 is paid by you. That's an out-of-pocket expense, and it's called a gap fee or payment. Just going to use an example to kind of explain that a little bit better. So a patient attends the GP clinic, the MBS states a GP service should cost $100, and that's just a random figure, I've just made that up. Under the MBS, the Medicare patients are eligible for 100% of the rebate of the schedule fee. So if the GP charged $100 and MBS states it should cost $100, that's what you get back, $100. But if you go to a GP clinic that charges $120, then the patient or you will only be eligible for the rebate on the MBS fee, which was only $100. So that means that additional $20 they've charged you is now going to be an out-of-pocket expense that you have to pay. So that $20 is a gap payment, and the $100 you will get back from Medicare. I hope that explains it further. Perhaps play that again if you don't understand, or get your trainer to explain it in your on-campus sessions. All right, so you're probably thinking that can get really expensive for patients that would have lots and lots of specialist appointments, because if you had lots of comorbidities, you'd need lots of appointments. So to help with this, Medicare has the Medicare Safety Net benefit. And just going to kind of skip what the slide says, but just to make it easier, what the Medicare Safety Net benefit says is if I pay a particular amount of gap payments and I reach a particular threshold set by Medicare within a calendar year, that any gap payments after that threshold is reached will be covered by Medicare. Well, sorry, 80% of that will be covered by Medicare. So I've reached my threshold, I still have specialist appointments, so I'm still paying gap payments, but now those 80% of those gap payments are going to be covered by Medicare for the rest of the calendar year. So obviously if you reach that in November, it's only going to be covered for November and December, because once January 1st ticks around, it starts over again. So what are the thresholds that you have to reach to be eligible for this? So it would be $400 for singles or families that have the Commonwealth concession cards, $700 for families who qualify for family tax benefit and single people without concession cards, or $1,000 for all other couples and families. So if you and your family pay $1,000 of gap payments or fees in one calendar year, anything additional to that, Medicare will cover 80% until January 1st. Hopefully that makes sense. Okay, so there obviously needs to be some sort of regulation on that, because Medicare would be forking out a huge amount of money. So patients that reach that threshold are entitled to a maximum Medicare benefit of 150% of the MBS fee for each service. Okay, and I'm going to do my best to explain this. Okay, so the patient has a specialist appointment. The MBS states that the fee should be $85.55. The rebate they will receive is $72.75, because the MBS states they should get 85% of a specialist appointment. So that's how much that is. Now, if you look at here, it's the MBS rebate plus the safety net benefit that will determine the patient's maximum Medicare benefit. So we need to work out how much is 150% of the MBS fee in this case. So if the MBS fee is $85.55, what is the 150%? So here's the formula to do it. So 150 over 100 times 85.55 is $128.33. We take out the amount that Medicare has already paid for that patient, which is $72.75, and that would leave $55.75 left over. So that means that this patient can only claim a maximum of $55.75 towards the Medicare benefit schedule. Now, it doesn't really make sense yet because there's no real figures, but keep that in mind. Okay, so this is what we just discussed. Remember, it's $55.75 as a maximum. So let's say this patient went to the specialist. The MBS fee is $85.55, but their specialist charged $120. So the gap payment that they've paid, which is $120 minus the Medicare rebate of $72.75, is $47.25. So that means that this gap payment was less than the maximum of $55.75, and therefore they can claim that whole amount towards their Medicare benefit threshold, so the Medicare safety net threshold, sorry. But if they go to another specialist who charges $150, the gap payment, so $150 minus the Medicare rebate of $72.75, is $77.25. So that means that they've gone over the maximum of $55.75. They can't claim that full amount. All they can claim is the $55.75. The additional amount above that will be an out-of-pocket expense. I really hope that made sense. It is a tricky concept. Took me a while to understand it. So I would suggest watching this part a few times over, or really reading through it, or again, get your trainer to explain it to you. Okay, the pharmaceutical benefits schedule provides subsidies on pharmaceuticals listed under the PBS and provides cheaper prescription medications for patients. So prescription prices vary based on the individual situation, so whether you have a concession card or not. So if the medication is not listed on the PBS, it's full price. So let me just quickly explain what this means. There is a big list of medications that is covered by the Medicare Benefits Scheme. What that says is, if you go to buy any of those medications, the government actually subsidises quite a large amount of the cost of that drug. So what you pay for the drug is actually not what that drug costs. You have a discounted price. So the co-payments are the amount paid by the patient, so you, as of January 2016. So if you don't have a concession card and you go to pay a medication, the most you'll pay is $38.30 for most of those PBS medications. So medication may cost $60, but because of the pharmaceutical benefit scheme, you'll pay $38.30. If you had a concession card, again, that medication might be $60, but you'll pay $6.20 as a maximum. The medication has to be on the PBS to be eligible for those subsidies. The RPBS, so administered by the Department of Veterans Affairs, so DVA, so provides access to pharmaceuticals and dressings at a concession rate for eligible war veterans, war widows, widowers, and their dependents. Now, a lot of people need to purchase huge amounts of medications, and that can be really costly. So we have the Pharmaceutical Benefits Scheme safety net, which says that once you reach a particular threshold of medication purchases that are listed on the PBS, you will receive either free medications or you'll be charged at a concession rate. So in January 2016, the thresholds are for concession card holders, $372. So if you have a concession card and you spend $372 towards PBS medications in one calendar year, any purchases after that within that calendar year will not be, you won't be charged for them. They'll be covered by Medicare. If you don't have a concession card, you need to spend $1,475.70 towards PBS medications. If you reach that threshold within the calendar year, you will be given medications at a concession price, which we saw was $6.20 instead of the $38.30. Now, again, just like the Medicare Safety Net benefit, if you reach that in November, you only get the discount or the benefit up until January 1st. Bulk billing, so you've probably seen that on GP clinics. What does it actually mean? So GP clinics can bill Medicare directly, therefore there's no out-of-pocket expenses, so you don't need to claim it back. So if it's bulk billing, they just bill Medicare, so you don't even need to worry about handing over any payments because you get 100% back anyway. And the Therapeutics Goods Administration, so that monitors, approves, and regulates the quality and use of medications, medical products, devices, and is funded by the Commonwealth Government. So if you click on that link below from your PowerPoint slides, you'll be able to access what the TGA actually regulates and what they don't regulate. Home and community care, so HAC. So HAC services are designed to assist people who are old and frail, have a disability, at risk of premature or inappropriate long-term residential care. So you will cover that as well in one of your other units. But it provides assistance with domestic duties, so cooking, cleaning, nursing care, personal care, and quite a few things. So it is slightly different in Western Australia and Victoria than in other states and territories. Workers' compensation insurance. So this is a compulsory form of insurance for employers to have in all states and territories in Australia. So its purpose is to provide protection to employees if they suffer a work-related injury or disease. So this will cover all medical expenses and the employee's wages while they cannot work as a result of an injury. The National Health and Medical Research Council supports health and medical research, develops health advice for Australian community health professionals and governments, provides advice on ethical behaviour in healthcare and in the conduct of health and medical research. Basically, they provide funding for research alongside with immunisations, screenings, which are ways for the government to support prevention of illness. So the funding of the healthcare system, so how much does Australia actually spend on the healthcare system? So 2011-2012, the costs were $140.2 billion, so a lot of money. Approximately 70% was funded by government, so 42.4% was funded by the Commonwealth and 27.3% by the states and territories. The remaining amount, 30.3% was funded by a mix of patients, private health insurers and accident compensation schemes. Patients about 17% and private health insurers 8%. So what does that money, that's a lot of money, what does it go towards? So the hospitals mostly at 40.4%, mostly to the public, primary healthcare 32.8%, majority to medications, and other reoccurrence at 21.3%, so majority to referred medical services. Pause the video here and you can see the percentages that go towards different areas of healthcare. Okay, so since 2011, the National Health Reform states that the states, territories and Commonwealth are jointly responsible for funding public hospital services using activity-based funding where applicable, or block funding in other cases. So basically the Commonwealth provides funding to the healthcare funding pool, and that gets distributed to the states and territories health departments, who then determine where the funding goes using activity-based or block funding. So HAC funding within Victoria, the Commonwealth and states and territory covers that. Within Queensland, it's the Commonwealth. Medications in public hospitals are free for public patients. That's funded by the state and territory governments. And I kept saying activity-based funding and block funding, so what does that actually mean? So activity-based funding is based on the number of services delivered to patients and the costs associated with those services. So for example, the services provided in an emergency department. So case mix is generally used for activity-based funding, so it helps to determine the funding based on the type and the type and number of patients that they have. So the requirements for that is classifying patient based on their diagnostic related group, and that could be patients that have pneumonia, patients that have appendicitis. So what are we giving them? You can have multiple DRG groups. Counting the number of patients that were treated and recording the treatment is really important. So you're able to show how the costs were calculated. Can be difficult as some patients with the same condition require different levels of care as well. And block funding is just a set amount given rather than based on the levels of activity. So they might give that to small rural hospitals. And just in regards to this, if you are a nurse, even though it's funding, it probably doesn't seem like we have a big role, but we do, because we need to make sure that we record the treatment appropriately. You're not going to allocate this, but you need to make sure that you're recording the treatment appropriately. It's very, very important. Medicare levies, so the healthcare system is partly funded by Australian residents who earn over a particular threshold. So we pay a Medicare levy of 2%. So when we were talking about the history before, it was originally 1%, now it's up to 2%. Medicare levy surcharge, Australian residents who reach a particular tax bracket who do not have hospital cover, so extras and auxiliary cover does not count, it has to be hospital cover. They're required to pay an additional surcharge of 1 to 1.5% of their taxable income on top of that 2% of the Medicare levy. Cross-border funding, basically, if you are from Queensland and you come to Victoria, or you're from Victoria and you go to Queensland and you receive healthcare out of the state you live in, you will still be covered by Medicare. So it's just a cross-border activity. The charges do get sent to that state, but that's not really something you need to be too concerned about. But that cross-border funding definitely happens. So just because you're from one state doesn't mean you can't get healthcare in another. Okay, so apart from federal and state funding, there's other non-government funds allocated towards health. So private for-profit organisations, so GPs, pharmacists, dentists, private hospitals, pathology services, private specialists, alternative practitioners, not-for-profit organisations, usually religious facilities, domestic or volunteers, so in-home facility unpaid support workers. So some fees go towards, or some funds go towards these areas, but not a huge amount. Private health insurance, so Australians have the choice to purchase private health insurance and when they can use it. So you can use a mix of Medicare and private health. You don't have to use your private health insurance if you don't want to. So there's two different types. There's hospital cover, which helps with the in-hospital treatment, both public and private, accommodation and theatre fees. Some MBS items can be covered. Items not under the MBS is sometimes cosmetic and laser eye surgery, but obviously that would be in a particular package. You'd have to check that. General treatments, which are your extras, could be glasses, contact lenses, prosthetics, hearing aids, dental treatment. So there are different levels of coverage and extras based on the policy. but those two types can be combined. So difference between public, private, and public and private. So just pause here and read this table. Lifetime health cover. So what this means is if by July 1st, following your 31st birthday, you don't have hospital cover, then you're going to be charged a higher premium when you do decide to take out private health insurance. So if you wait till you're 32 and you decide, I'm going to take out private health insurance now, on top of the premium, you're going to be charged an additional 2%. If you wait 5 years after your 31st birthday, it's an additional 10%. If you wait 10 years, so now you're 41, you're now going to get an extra 20% on your private health insurance premium. So that's quite considerable. The reason that this is a thing is because the government wants to encourage people to take out private health insurance early in life, so it takes some pressure off the public system. If you're new to Australia and you're over 31, you don't have to pay this, but you do need to take out private hospital cover within 12 months of being registered with Medicare. Okay, so what are some strengths of the Australian healthcare system? Well, universal access to healthcare. Everyone can access it as long as you are eligible for Medicare. Otherwise, you can still access it, but it will cost. Choice between public and private healthcare. You don't have to go public. You don't have to go private. High quality services, equitable financing of healthcare, some evidence of accountability and efficiency, and high level of education for all healthcare staff. And your weaknesses, there's long waiting periods for elective and non-urgent surgeries in the public sector. There's delays for admission from emergency departments because they're so busy. There's closure of hospital beds due to funding issues, heavy funding for the acute care services. There needs to be more funding for primary health care. There's problems related to inequality and inequity, so accessing healthcare. Need for more coordinated client care between hospital, home and community services. Multiple layers of healthcare delivery, so state and federal, with tensions regarding who pays for what, and tensions between public and private providers of healthcare services. I know that seems like a lot of weaknesses. I think it's more that the sentences are longer because the Australian healthcare system is actually quite good. Okay, I know that was a long lecture. You've done really well. There is only one lecture after this, and there is a video within this lesson to further explain how the Australian healthcare system works. So if you found that you're not really understanding after this lecture, I really encourage you to watch that video. Thanks, guys. Bye.